the thyroid hormones. I hope you must have read it. So the thyroid gland secretes the thyroid hormones, that is T3 and T4. T3 is triiodothyronine and T4 is thyroxine. Now, important steps in synthesis of thyroid hormone. Here, first is iodide uptake, then there is oxidation and iodination, coupling, storage and release. Now we will see those steps in detail. This is a diagram which I have taken from KD Tripathi. So you will be getting this diagram over there. Now important constituent of thyroid hormone is iodine. So iodine from the dietary sources, it will be absorbed from intestine, it will be entering into the circulation. Now this is a follicular cell, this yellow structure, and this portion is a colloid where the thyroid hormone is stored. Now iodide ion, which is present in plasma, it will be taken inside this follicular cell. Now this step is called as iodide trapping. Now this NIS is sodium iodide symporter. So this symporter is responsible for trapping of iodide ions. Now this is an active process. It is a concentration dependent process from higher concentration to the lower concentration one. Then this trapped iodide, it will be taken inside to the colloid portion. Then this iodide will interact with hydrogen peroxide, that is H2O2, in the presence of thyroid peroxidase enzyme. Then it will form those hypoiodous forms. So this is a step of oxidation. Now those hypoiodous forms, it will combine with the tyrosine residues of this thyroglobulin molecule. Then there is formation of MIT and DIT. Now MIT stands for monoiodothyronine and DIT is diiodothyronine. So here there are two molecules, and in MIT there is one molecule. Then the next step is coupling. So coupling, in that MIT and DIT combine to form T3 and T4. So T3 is formed by combination of one molecule of DIT and one molecule of MIT. T4 will be formed by two molecules of DIT. So this is a coupling process. So at the end of coupling, we are getting our active hormones, that is T3 and T4. Now that will be stored in the colloid structure. Here you can see the colloid in the center. Then the next step, whenever there is release of thyroid hormones from the gland, what happens is that endocytosis. Endocytosis is nothing but taking up of those thyroid molecules into this particular cell. It will be again taken inside. It will be acted upon by protease enzymes. So there will be proteolysis, and we will be getting the T3 and T4 hormones, which will be secreted out. Okay. So the steps are iodide trapping, oxidation here, then there is a coupling, endocytosis, proteolysis, and there is secretion. There is T3 and T4 is released. After release, 40% of T4 will be converted into T3. This is called as peripheral conversion. So this happens by the process of deiodination. That is, one molecule of iodine will be removed. So, moving forward, we'll see short about all those steps. Iodide uptake, I told you that there is sodium iodide importer. It is active transport. Important thing is TSH stimulates this process. Now, what is TSH? You should know. This is a thyroid stimulating hormone. So, this is a very important hormone as far as synthesis and release of T3 and T4 is concerned. So, iodide uptake is dependent upon the TSH levels, mainly for the thyroid gland. For other organs, it is not TSH dependent. So, there are other organs also like skin, salivary gland, mammary gland, where there is iodide uptake. Okay. Now, next is oxidation and iodination. So, I told you that there is thyroid peroxidase enzyme which brings about the oxidation, formation of those iodous forms. They will be combining with the tyrosine residues and there will be formation of MIT and DIT. This step will be again stimulated by TSH. This is very important thing that all those steps are TSH dependent. Okay. And it is inhibited by thiamides. Afterwards, we'll see the thiamides are anti-thyroid drugs which can inhibit those steps. Now, coupling, I told you that how the T3 and T4 is formed. Then it is TSH dependent. So, this is T3 and T4 formation. Again inhibited by thiamides, the anti-thyroid drugs. Storage and release will be stored in the colloid. And for release, there is endocytosis and proteolysis. Again, TSH. So, all the steps which are involved in synthesis and release of thyroid hormone, that is iodide uptake, oxidation, coupling, endocytosis, proteolysis, that is release, all are TSH dependent. So, adequate amount of TSH is needed to accelerate all those steps. So, this is a key element which you should remember. So, T4 and T3 are released in circulation. And other byproduct, that is MIT and DIT, will be deiodinated and reutilized. Peripheral conversion, I told you that 40% of T4 will be converted into T3 in liver and kidney. Now, there are certain drugs which inhibit this peripheral conversion. So, this is again important thing. So, one is propylthiouracil, which is this is an anti-thyroid drugs, which will deal it in the next class. Then there is propranolol. Propranolol, you know, which is a non-selective beta blocker. So, propranolol in higher doses, it also inhibits this conversion of T4 to T3. Then there is amiodarone, which is an anti-arrhythmic agent. Then there are glucocorticoids. They also inhibit the peripheral conversion. So try to remember those names because they are used afterwards. Then after synthesis, it will be released in the circulation in plasma. In plasma, it will be binding to the thyroid hormone binding proteins, that is thyroid binding globulin, TBG. So in plasma, there will be two forms of those hormones. One will be a bound form and one will be a free form. So there will be free T4 and T3 and there will be bound T4 and T3. Okay. Now another important thing is that this thyroid binding globulin levels are increased. One is by estrogens during pregnancy or when the female is using oral contraceptive pills. This also again we need to keep it in mind. Now why it is important? It is related to the plasma protein binding. We have already discussed it in the pharmacokinetics that the drug remains in the bound form as well as free form. Out of those two, free form is the active form of a drug. So when binding increases, the free form will be reduced, and it will result into the deficiency. So if a female is there who is hypothyroid, you are giving thyroxine to the patient. During course of time, she becomes pregnant. So there will be increase in the level of TBG. So this thyroxine will be bound or it will get bound to that TBG so that the free level will be decreased and that will result into hypothyroidism. So therefore in this case you need to increase the dose of thyroxine. Get it? So we can avoid the deficiency or will be able to maintain the free level of the drug, the hormone. Now some of the differences between T4 and T3. Now T4 it is a transport hormone in the body. T3 is a active hormone. T4 is a major circulating hormone. T4 it is less potent and it is having slow action. Its action needs 1 to 2 days. T3 is comparatively more potent. It is having a faster action. That is within 6 to 8 hours action will be there. There is a difference between peak effect. For T4 it is 6 to 8 days. T3 less time, 1 to 2 days. Binding with the nuclear receptor, we'll see that the thyroxine hormone it binds to the nuclear receptor. The binding is more with the T3. This I told you that is transport hormone and active hormone. The free T4 level is 0.03% of the total. In case of T3, it is 0.3% of the total T3. Okay. So, moving forward to the mechanism of action. So I told you that it is acting through the nuclear receptors. This diagram you must have already seen in the pharmacodynamics. It is there in Tripartite diagram of nuclear receptor, how it acts. Now you can see this is the cytoplasm of the cell. Here this is the nuclear portion. So this thyroid hormone, this is the receptor for this thyroid hormone. So usually the co-repressor will be bound to this receptor. So when the thyroid hormone, that is T3, it binds to this receptor, there occurs a conformational change in the receptor structure so that this co-repressor will be removed and the co-activator will be attached on it. So it will activate this receptor. So there occurs dimerization of the receptor. You can see this. This is the thyroid receptor and this is a retinoid receptor. It is dimerized over here. Then this activated receptor, it will be moved towards this DNA structure and it will stimulate the specific gene sequence in the DNA, that is TRE, thyroxine response element or thyroid hormone response element. So that is a TRE. So it will be stimulated and then there will be transcription and transmission, synthesis of mRNA and different proteins. Okay. We have seen that T3 is having more affinity towards the nuclear receptor. So T3 will be crossing this cell membrane, cytoplasmic membrane. It will be entering into the nucleus and it will be bringing about all those actions. So the thyroid hormones. Okay. So this is the mechanism of action acting through the nuclear receptors. Now moving forward, again the same thing, mechanism of action in this one. The binding to it. How about the actions for which the thyroxine hormone is responsible? One is it is responsible for the growth and development. Now it is intrauterine as well as extrauterine growth and development. So important organ is the brain or nervous tissue, whose development is dependent upon the thyroid hormone levels. So if there is deficiency, there will be defective development of the brain. In intrauterine life, it will lead to cretinism. In extrauterine life, it will affect the physical growth of the body. So on X-ray, in this case, one can get epiphyseal dystenesis, X-ray of the bones. So there will be porous, fluffy, and fragmented appearance, and there will be reduced levels of serum alkaline phosphatase. So brain and nervous tissue development is dependent upon the thyroxine hormone levels. Therefore, we need to maintain those levels when a female is pregnant, so that the baby or fetus should not suffer with the deficiency because it will result into development of cretinism. Second action is calorigenesis. The hormone increases the synthesis of ATP, increase oxygen consumption, and ultimately increases the basal metabolic rate. So the heat production will be increased. So any time the patients whom the hormone levels are increased, they develop heat intolerance. They are unable to tolerate the heat. Then action on cardiovascular system, that is CVS. There it is having the genomic action as well as non-genomic action. So that is, it will be acting on the heart. It is increasing the force and contraction of the heart muscle. The cardiac activity will be, contractility will be increased, the cardiac output is increased. Another component of action is it increases the sensitivity of the heart towards the catecholamines. Wait for a minute. These are the serious actions. So ultimately there will be a hyperdynamic state. Heart rate, contractility and output is increased. And there is increased sensitivity to catecholamines. So if you know thoroughly the actions of thyroid hormones, you will come to know the symptoms which will be there in hypothyroidism and hyperthyroidism. So if the thyroid hormone level is increased, the patient will be having tachycardia, palpitations, increased cardiac output because of this action. Now next action is action on metabolism. So on lipid metabolism, there will be rise in serum cholesterol level. This lipolysis is seen. That is the action of catecholamines. On carbohydrate, there is increased sugar utilization by tissues in the presence of thyroid hormone. Again, the glycogenolysis, gluconeogenesis, and absorption of glucose from intestine is increased. So therefore, in higher doses of thyroxine levels, there will be diabetes mellitus type state because blood sugar level will be increased. On proteins, physiological doses is having the anabolic action. Increase in the protein synthesis will be there. In higher doses or at toxic doses, there will be negative nitrogen balance or the catabolic action will be there. Okay, so this is about the metabolism. Now, there are some differences between the symptoms, hypothyroidism and hyperthyroidism, which you should know. Because when the case will be presented to you, it will be having those symptoms, and from those symptoms you can guess about the diagnosis. On nervous tissue, in hypothyroidism, there will be sluggishness or mental retardation. In hyper, the patient will be anxious, will be having tremors. Again, we can give you history about insomnia, difficulty sleeping. On skeletal muscle, in hypo, they will be flabby and weak. Hyper, there will be increased tone in muscles. GIT, in hypo, there is constipation. In hyperthyroidism, there is diarrhea. Hemopoiesis, there is anemia in hypothyroidism. Then in reproduction, oligomenorrhea and infertility. So most of the time in females, hypothyroidism will be diagnosed with the problems of menstruation. So they will be having menstrual problems. There can be oligomenorrhea or there will be history of infertility. So in that case, you can raise a suspicion of hypothyroidism. And you can ask the patient to do the thyroid function test. Now this is something about the regulation of thyroid hormone levels. Now there is hypothalamus. Hypothalamus, you know that it releases various releasing hormones. So this TRH, that is thyrotropin releasing hormone, it will be released from the hypothalamus. It will be acting on anterior pituitary. Then from anterior pituitary, there will be release of TSH, that is thyroid stimulating hormone. Because of that, there will be release of thyroid stimulating hormone. It will act on thyroid gland, and then the T3 and T4 will be released. Now there is something called as feedback inhibition. The T3 and T4, which is released in the circulation, they will provide a signal to the hypothalamus as well as anterior pituitary. So this is a negative effect. And because of that, the further release of TRH or TSH will be reduced. So that further synthesis of thyroid hormones and their release will be stopped or it will be decreased. So this is the concept of feedback inhibition. So when in patient's body there is increased levels of T3 and T4, for example hyperthyroidism, then those levels will give a signal. There will be feedback inhibition. In that case, the TSH levels will be reduced. So in this patient, if you do the thyroid function test, you will be getting increased levels of T3 and T4 and reduced level of TSH. So in hyperthyroidism, TSH will be decreased. And the reverse will happen in hypo. So when there is reduced level of T3 and T4, there will be loss of this feedback inhibition. As there is no feedback inhibition, the TSH level will be increased. So in hypothyroidism, when you do the thyroid function test, the TSH level will be raised. Now, about the thyroid preparations. Yes, this is about thyroid function test, hormones and their normal values. So, you must be knowing this, that what are the normal values, normal plasma levels of T4, T3 and TSH. So, whenever you are having any report of thyroid function test, you should be able to study that report based on those values. So, T4 it is 4 to 11 microgram, T3 60 to 180 nanogram, and for TSH it is 0.5 to 5 microunits per ml. So TSH you should be checking specifically. It should be maintained in this particular range. Okay. Then we'll see about the thyroid preparations, which preparations are available. So up till now, you know that there is thyroxine and there is triiodothyronine. So both are having tablets as well as injectable preparations. That is L-thyroxine tablet as well as injectable preparations are there. See this. Now about the tablets, the tablet, for example, L-thyroxine tablet, it should be given early in the morning before breakfast on empty stomach, so that it can increase the absorption of the drug. Now the drugs of the atoms like supraphate, iron, calcium, all should not be given simultaneously with the thyroid preparations. There should be a gap of 2 to 4 hours because they hamper the absorption of the thyroid hormones. Again, there can be interaction with the enzyme inducers. We'll see. Clinically, L-thyroxine is preferred over neothyronine, that is T3. Now, in comparison, we have seen that T3 is having fast onset of action. T4 is having comparatively slow onset of action. But again, as in those patients, we know that the hormone, thyroid hormone, they act on the heart, increase the contractility, cardiac output. Again, they increase the sensitivity of the heart towards the catecholamines. Now, in hypothyroid patient, there will be increased levels of, there will be obesity. Obesity will be there, increased weight gain, cholesterol level will be more. In that case, if you give neothyronine, which is faster acting, will be acting on the heart, stimulating the heart, increasing its contractility. So, because of this, there is increased chances of MI if you use a faster acting thyroid hormone in those patients. So, therefore, to avoid that, we use L-thyroxine in those patients, though it is slow acting. Okay. So, this we have seen about the uses. Uses, you will be knowing that one is cretinism. So the dose is 8 to 12 microgram per kg per day. Thyroxine is given. Increase the dose every fortnightly, that is after every 15 days, then increase the dose. The total dose to be taken before breakfast, early in the morning, with a glass of water to increase its absorption. So it should be a lifelong therapy. Now this is the thing which one should convey to the parents, that lifelong your child should be taking this particular medication. Now adjustment of dose, how we are going to adjust the dose, it depends upon the plasma free T4 levels. So in between, or for example, after 15 days, we will be measuring the plasma free T4 level, and it should be in this range. If it is not there, we can increase the dose. Then mental milestones. Milestones can be checked in that child. Rate of linear growth or bone age, that can be seen. Okay. This is the way how you do treat the patient. Important is it should be a lifelong treatment and the dose adjustment. How we are going to do the dose adjustment. In adult hypothyroidism, the causes are mainly can be because of infection, because of the thyroidectomy, because of certain drugs. There are certain drugs which cause this hypothyroidism. We can start with a dose like 50 microgram per day in adult patient. We can start with this. After a period of time, maximum dose that is 100 to 200 microgram per day. In IHT patients, patients who are having ischemic heart disease, we know that thyroid hormones are acting on the heart, increasing its contractility. In those patients, we can reduce the starting doses. Then give, for example, 12.5 microgram per day. So this is an important thing which you should remember. Those adjustments are made over a 4 to 6 weeks. So initially, after a period of 4 to 6 weeks, you repeat the thyroid function test, check the Phe levels, also the TSH levels. On that basis, you can increase the dose. So this you can do till the patient gets stabilized or till he achieve the normal levels, and then you can repeat the thyroid function test every 6 monthly or yearly when the patient is stabilized. Pregnancy needs dose increase. This I have told you that there is increased level of thyroid binding globulin. So more and more hormone will get bound to that globulin. The Phe level will be reduced. So it can result into hypothyroidism. So to avoid that, you need to increase the dose. Check for cortisol deficiency. Many of the patients who are having hypothyroidism, there is associated deficiency of corticosteroids also. So therefore, simultaneously we should check for that. And if the patient deficient, we can give steroids, prednisolone or hydrocortisone according to the need. So TSH level, that is 1.5 microunits per ml, to be maintained between this. Drug-induced hypothyroidism. Now, which drugs induces the hypothyroidism? These are some important drugs I mentioned over here. One is lithium, which is an anti-maniac drug. So, lithium, when it is given to the patient over a longer period of time, it can cause hypothyroidism. Then there is amiodarone and propylthyrosine. Now, amiodarone and propylthyrosine, we have just now seen in this class only that they are inhibiting the peripheral conversion. That is conversion of T4 to T3 will be inhibited by those two drugs. Okay. And T3 is an active hormone. So whenever there is deficiency of T3, it will result into hypothyroidism. Okay. Then next is radioactive iodine. Radioactive iodine causes destruction of thyroid gland. So it can again result into hypothyroidism. Radioactive iodine is an anti-thyroid drug. It is used in patients of hyperthyroidism or thyrotoxicosis. In that case, when it is used, it will cause destruction of thyroid gland. And because of the destruction, there is a chance of developing hypothyroidism. So in those patients also, we need to give thyroxine. Avoid it. Okay. Now next use of this hormone is in eczema coma. It is an emergency condition of hypothyroidism. Severe hypothyroidism will be there. The patient. Now we have seen in symptoms of hyper and hypo. In hyperthyroidism, there is heat intolerance. The patient is unable to tolerate the heat. In hypo, there is reduced production of ATP, so there is cold intolerance. So mainly in winter seasons, when there is severe cold and if the patient is hypothyroid, there is a chance of developing eczema coma because of the deficiency. So it will be mainly in cold weather. About the clinical features, so they are like that of hypothyroidism, that there is hypothermia, reduced body temperature, bradycardia, hypotension, and cold. That's things. Then the patient can have respiratory difficulty. And it is emergency condition, we need to hospitalize the patient in ICU. There is deficiency of thyroxine, so we will be giving thyroxine to the patient intravenously. So it is L-thyroxine 1/50 to 300 microgram IV, followed by 100 microgram IV OD. So this is the dose. Intravenously we are giving the drug to the patient. In some cases, They say that you can give T3 also because there will be hampered peripheral conversion. Peripheral conversion will be hampered. So in that case, you can give IVT, that is 10 microgram IV 8 hourly. If there is associated cortisol deficiency, IV glucocorticoids, because many of the patients they suffer with this. IV glucocorticoids can be given. Okay, so L-thyroxine is the main drug given intravenously. Along with that, there is T3. And glucocorticoids they are giving because most of the patients they suffer with the low adrenal reserve or the corticosteroid levels will be reduced in their body. Therefore, there will be IV glucocorticoids like hydrocortisone. Again, according to the symptoms, we know the patient will be having cold intolerance, so there is slow warming of the patient's body. There is infection, antimicrobials. Patient is having difficulty in breathing, so there is respiratory therapy. Monitoring of fluid and electrolyte balance, we know that there is hypotension. Correction of hyponatremia and hypoglycemia. So, we need to correct it, maybe exposed to the patient. ACL. This is about the management of eczema coma. The photograph of patient having eczema. Another uses of thyroxine hormones, that is a non-toxic fighters. Where the TSH levels are normal, but still the patient is having goiter. That is increased size of the thyroid gland. The goiter. And this they say is mainly because of local generated growth factors. Now in this case, it is non-toxic. Means the hormone levels, that is T3, T4, TSL, they are normal. No problem with those hormone levels. Only there is goiter. That is the gland size is increased. And this is because of the locally generated growth factors. The important thing is there here is TSH acts on thyroid gland and it increases the vascularity of the gland. And again, it results into the weight gain. Weight of the gland is also increased. So this size increase, there is weight increase. So it is dependent upon the TSH levels. Next thing, in thyroid carcinoma patients, there are TSH dependent carcinomas. In this case, if you give higher levels of thyroxine, we know that there is feedback inhibition. If there are higher levels of thyroxine thyroxine in patient's body, it will inhibit the release of TSH. So we can check the TSH dependent carcinoma. So their growth can be checked or it can be reduced by giving thyroxine in higher doses. Now, thyroid disorders in pregnancy, I told you already that comparatively 30% increase in the dose is needed as compared to non-pregnant state. TSH should be monitored as follows. So they say that in first trimester, you try to maintain the TSH less than 2.5 millunits. In second and third, will be 3 millunits. So this range we need to maintain. And we are increasing the dose, 30% increasing the dose. This I told you already because of increased levels of TBG. Now there is something related to iodine. We know that iodine is an important constituent of thyroid hormone. Iodine we are getting from the diet. So daily requirement of iodine is 1 to 2 microgram per kg. So they say that 200 gram of sea fish 2 times in a week plus unpurified common salt. You want to know there is something called as sindhu. Sandhol salt is there. So they will give you adequately the iodine. Now to supplement the salt which is available there, they are doing iodization of the common salt. How the salt is iodized? They add 50 to 80 milligram of sodium iodide in 1 kg of common salt. This is the iodization of the salt. Another thing to maintain the iodine requirement, there are some injectable preparations, injectable liquid which contains iodine. So 1 ml intramuscularly every 2 to 5 yearly can be given to maintain the iodine status. Now you must be knowing there are certain regions in our country where the iodine content is less in the soil or water, mainly sub-Himalayan region. So in those regions, people mainly suffer with hypothyroidism. So in those, there they need the iodization of the salt or those injectable preparations. Okay. Now for today's class, we'll stop here. Today we have finished how the thyroid hormones are synthesized, how their release is regulated, what are the normal values of TSH, T3 and T4, what are the different actions, how they are used, what are the differences between T3 and T4. So for the next class, you read all those things properly, and in next class you deal with the anti-thyroid drugs. Right. Okay. So thank you very much for patient listening. Have a nice day. If you are having any queries, you can WhatsApp your queries or you can call me. Thank you.